Good morning, ladies and gentlemen. I'm Euihong Lee from Asan Medical Center. I would like to express my sincere welcome to the Cardiovascular Summit TCTAP 2019. Today, in this main arena, we will have 3 consecutive sessions, including 2 live transmissions from Asan Medical Center. And at the end of these sessions, there will be an announcement of TCTAP Award, Master of the Masters. So let me start this conference with the first live transmission session that will focus on the transcatheter aortic valve therapeutics. I would like to invite Dr. Martin Leon and Dr. Myung-gi Hong to the stage for moderation, and Dr. Vinayak Bepat, Dr. David Cohen, Dr. Tien-Ping Sao, Dr. Paul Kao, Dr. Thierry Lefebvre, Dr. Greg Stone, Dr. Alain Young for discussions. Okay, now I think Dr. Bach is ready for the live. Let's move on to the Asan Medical Center.
Good morning, Dr. Ba.
Yeah, right. Good morning, everyone.
I'm Hong.
Right.
And my co-moderator, as we know, Dr. Leon. And
right.
we have several very distinguished panelists, Dr. Bapat, Dr. Cohen, Dr. Kao, Dr. Lefebvre, Dr. Siebert, Dr. Stone, Dr. Sao, and Dr. Yoon. And as you know, this session is a future perspective of TAVR from high risk to the low risk. Before the beginning of your cases, I have to say that the congratulations of the Partner 3 trial. Now we have a more comfortable situation to provide the TAVR procedure in a low risk patient. Okay, please.
Okay. All right. First of all, I'd like to thank you for the distinguished faculties, Marie and Greg, Maurice is all my friend here, and also before we wanna start our first cases on TAVRs, I'm really happy and honored to have that who he is and the legend of our TAVR and intervention cardiologist, Alain Cribier here, and our cardiac surgeons, our junior colleagues, Dr. Kang here. And so I am really very happy in terms of TAVR procedures. He is actually my mentor. So we started with the 2010 first cases with Alain Cribier. So we have a very good memories, right?
Yes, well, it was a very difficult case, I must say.
right. So today is again, I really, thank you for coming. And
it's my pleasure again to be here.
Right.
Yeah, thank
SJ,
you.
this is Marty Leon. I just wanted to say hello. Behind those masks are some of the most impressive people that have ever held a catheter. And not only is Alain Cribier your mentor, he is all of our mentor. And before there was a partner 3, there had to be a partner 2 and a partner 1, and there couldn't be any partners if it had not been for Alain Cribier. So it's a pleasure to see Alain in the cath lab again, and we're all indebted for his contributions.
Right. So
thank you very much, Marty.
All right. Anyway, as Marie, you are there, the Cribier is here, and so I'm very honored to have you all. All right, we're going to start first cases, and so Dr. Kang will present our patient history brief.
Yes, I will introduce our first case. The patient is 82-year-old lady, admitted for exertional dyspnea. She only has the medical history of hypertension, and she was diagnosed as a severe degenerative aortic stenosis with normal LV systolic function. Next. And her STS mortality score was 2.9%, low risk type of patient. And next, and the echocardiography showed severe AS with normal LV function, and ECG showed right bundle branch block. Next. And this is our CT measurement, or routine CT measurement algorithm. The annulus area was 370, and annulus short and long diameter was 20.3 and 23.9. Next. And the sinus valsalva area to annulus area ratio was 2.0, and ST junction to annulus area ratio was 1.6. And next. And the LVOT shows a clear landing zone morphology without calcification. And next. And this is our the amount of calcium. The total amount of calcium was 310 cubic millimeter, or less than average. Next. And you can see the shape of the calcification, and you can see the clear LVOT. Next. And coronary height is sufficiently high. Left coronary height was 30 millimeter. Next. And iliofemoral artery is large, and next, a little bit tortuous, but there was no problem to advance. Next. And this is a sizing chart for Sapien 3 valve. And
So, Alain,
Yeah.
what do you think the case brief in terms of,
Well, you did a perfect screening of this patient, and she is a short woman,
Yes.
and as expected, we are moving to a 23 millimeter valve,
yes.
which will be a little undersized in comparison to the annulus, I think by 10%. So maybe could we start inflating the 23 millimeter valve first, and in case of need, we could add 1 milliliter of contrast to get to a little oversize. But well, actually, it's a kind of regular case. I think the most impressive part of it is the tortuosity of the femoral arteries, which is quite bad. But you had no problem.
Yes,
in
I had
advancing
no problem.
Oh, so well,
Yes.
we can expect not to have. With the commander delivery system, we can do miracles. In crossing this kind of femoral arteries and iliac vessels. So well, I think you made the right choice. No problem.
Okay, thank you. All right, so we have a consecutive 3 cases, and so we're going to start soon. So in terms of procedure-wise, we didn't do a general anesthesia anymore. It's almost all more than 90% of cases we do conscious sedations with the anesthetic team. And I would like to introduce Dr. Kim from the echocardiographic division. So, always get together.
That's good. Great.
Our team cardiac surgeons, and I'm very proud of that one. Okay.
So, SJ, are you going to pre-dilate this valve?
You mean?
Are you going to pre-dilate with a balloon?
No, we are not planning to pre-dilate this patient now, because the calcification is relatively moderate, and so it's not really necessary.
Yeah, I was going to say, in this case, I don't think you need to pre-dilate.
No.
In the Partner 3 trial, about 60% of the cases were pre-dilated, but that was more by recommendation. I agree that with this device, Sapien 3, it's, in some cases we do, but in most we don't anymore. Okay. I would, with a baseline right bundle branch block, I would try to keep the inlet of the valve as high as you can in the annulus.
Yes.
Because she certainly is at risk for complete heart block.
This is typical cases for the Partner 3 cases, a low-risk patient, and actually good indication for the TAVI procedure. Any other comment over this case?
15% of the patients in Partner 3 were over the age of 80. So she's a little bit older, but other than that, she really has no risk factor. She's really an excellent candidate.
Yeah.
Would you still use a temporary pacing lead, or you would just pace through the wire with this existing bundle branch?
Yes, actually, I think are you pacing with a pacing lead or through the wire?
We have
You have a pacing lead?
Yeah, we would definitely use a pacing lead. There's a new wire, which is a pre-shaped wire that has just been made available, that has 6 electrodes on the LV wire that allows you to pace very predictably from the LV on these cases. We haven't used it yet. It's not been made available, but that's going to be made available soon.
So just making the alignment procedure.
You know, it's funny, this is a Sapien 3 where you have to do this docking maneuver in the descending aorta. We're now working with the Sapien Ultra at Columbia where it's all on balloon, where there's no docking anymore.
Absolutely. I think that's one step less.
Yes, just
and it's very
fine-tuning.
convenient.
I think also, Vinny, in a case like this, where I guess they're going to use a 23 valve, I like the fact that the hemodynamics seem to be better on an Ultra than on the Sapien.
And I was just going to comment on that.
Okay.
The other thing we have seen in Colombia now with
All
use of Sapien Ultra is that it by nature deploys higher. So in this patient, as you mentioned, has right bundle branch block. That becomes
well,
an
it doesn't
additional
do-
advantage in using
I
Ultra.
think it's okay.
So we just have to leave it.
So as you see, they're not using cerebral embolic protection. You know, that's an interesting discussion, but
Okay, I would like to feel the
Just a little more,
pushback.
and we can check the position now.
All right, why not? Here we are.
Yeah.
Test, please.
Yes, it's
too-
too low.
I think it's too
Too
deep.
low.
So I want to
Just,
put
yeah.
the
so this device
LV
shortens from the ventricular
All right,
side.
test, please.
What we like to achieve is to place the marker
The balloon
just
is a
above
bit
the
forward
same line,
A little
by
bit
1
high,
millimeter.
yeah.
Huh?
Marker is
What
pretty
do you think?
forward.
Alain, it's okay? Test, please.
Yeah, remember, it's not quite centered
the
on
balloon
the
high.
balloon.
is slide forward, so be
Just
careful.
Not too much, like
All right,
this.
right,
okay.
right. I know.
So the
Test,
device
please.
is actually slid back on
What
the
is
balloon
it?
a little
It's
bit,
okay?
so just be
Yes,
aware
I
of
think it's
that.
fine.
Because the middle
it's fine.
marker is now more towards the ventricle side than the middle part.
Yeah, yeah. I would have moved it back just by 1 millimeter, you know, just to avoid the risk of permanent block. So
I'm sorry. I want to
it
make
may be a little too low.
All right. I want to make it a little bit more
Can you do again a shot? Can you shot
coaxial.
again?
Okay,
in the
now
auto?
test, please.
Yeah, it's a
It's
little
okay?
low. It's a little
Little
low.
low?
I think we'll. You can move it back
No, the markers is
by 1
okay.
millimeter.
Really?
I would
markers-
move it
markers-
back by
Right,
1
right,
millimeter,
right,
you know,
right.
because it's
Okay.
the marker should
why-
be just above the science line.
Okay, test, please. Okay.
Well, this is
it's okay.
better. It's still a little low.
So
but, okay.
you have to think about
Okay.
the stent itself is a little bit moved,
Okay.
you know,
No,
up
it
to.
will-
All right, test, please. Okay.
It's okay.
Okay,
All right. It's okay.
so you give the order.
Yes.
This is about 10%
Pacing,
oversized for a
pacing,
23,
please.
which should be fine.
All right. Contrast. Okay. Inflate. Full shot. Good, great. Good, great.
It was very fast.
That's the fastest.
All right. Keep
Very,
it.
very quick inflation, yes.
Okay, that's fine. That was a very quick inflation.
All right.
I think, Professor Park, this was much slower than last year.
Can you? Okay.
All right. So
We have
really
just straightened
calm.
the.
All right. We did the oh no wiring.
Ultrasound in here.
All right. So
No,
our Professor Kim is very well at the transthoracic course and made it after the procedures.
Can you see
this is the
the equipment?
fastest inflation that I have seen.
Oh really? All right. The position wise is perfect, right?
Yeah.
So is the echo? That's
Yeah, can you see the echo imaging?
Over there.
fine? Oh, okay.
Yeah, this is the shield axis image.
Well, I think the result is fine. Huh?
The procedure itself is very simple and very fast. What is your expectation for the discharge of this patient after the TAPA procedure?
Well,
3 days.
actually, I think they used to keep the patient 3 days. Well, in our institution, we managed to have the patient discharged before that, so make the hospitalization as short as possible. And we are doing the minimalist approach in 100% of cases. No patients received any general anesthesia. And the family and the relatives are really advised that we have a short hospitalization politics in the hospital. This is very important that everyone is informed, you know. So sometimes, you know, we have even patients leaving the hospital at day 1, but we are not pushing too much to have the patient out as soon as possible, you know, 1 or 2 days.
Yeah, I can. SJ, can you see the rhythm? What is the rhythm now on an ultrasound? It's a little.
I mean, I think the patient's in heart block, aren't they?
Some dissociation with the AB, right carriers, maybe accelerated junction.
I mean, the real issues
fully
now are
dissociation with
paravalvular
the-
leak and what is the rhythm.
Very trivial, probably, mainly central AR.
Cross section.
You want to do an aortogram before leaving, or?
Yes.
Is there any imaging specialist, please comment about the echo finding after the valve
Yeah,
deployment?
but in parasternal long axis view, wait a minute.
Please comment.
The device placement is 80 to 20, 190
Yeah,
to 10.
that's
I
okay.
think it's perfect.
Can you see the echo image right now?
Yes.
Yeah, the device position is very good. On color flow exam, no power leak on long X images.
Yeah, we don't like to leave the lab, even if there's mild PVL, and if it's...
Yes, it looks...
Yeah, almost
looks
no
like
PVR right here.
All right, so we're going to do aortogram. Just, would you
Now, she's 82, so I think you have to have reasonable expectations.
release tension, please? Okay, good, perfect. Okay, take
So
a
we
picture.
have an aortogram now.
All right. Oh, shot.
Well, it's very acceptable, but
All right.
if we wanted, we could add 1 milliliter, the wire is in,
Maybe,
so I
yeah,
think we,
maybe central.
yeah.
The
Central,
relation
maybe
to wire.
central.
Yeah, one of
All
the
right.
things that's
So
difficult
I think
because,
it's okay for her,
because you have a
she's
stiff
82
wire, and these bovine pericardial leaflets are easily pinned by the wire. So some of what you're seeing could be central.
So we can remove the guide wire and do it again.
All right,
Yeah.
and hold the wire out, and maybe
Wire out.
another cases will show LV pressure. In the other cases, however, we're gonna pull the device out.
You tend to get a little bit more wire pinning with the shorter bovine pericardial leaflets than the longer, thinner porcine pericardial leaflets that's used in the
Oh,
core
all right.
valve,
I
for
think
instance.
it's okay. You don't need that one. All right, take a aortogram again, and you're gonna finish the rest. All right, ready? Shut.
Well, this is good,
Yeah, very
I think it's good enough,
It
right?
looks at most to be trace.
All
It
right, so
doesn't-
you,
Yeah, I think we can stop there.
yeah, Alain, so you are really surprised. It's a fast inflation, right?
Yeah.
Remember you've seen that, right? And so,
Actually,
all
I
right,
was,
so we started with the you mentioned about slow inflation, and getting more experience.
Okay.
So we're getting
That's
faster. So, all right, so
Okay,
all right,
finished?
why not? All right, all right.
Congratulations,
And, all right, so we're gonna move second cases, and you're gonna discuss more in detail, right? All right,
okay,
great,
fine.
great. Thank you.
Thank
All
you. Okay. Dr. Bach.
Okay, hello. Okay, yes, thank you. The second top case, we prepared the different risk case. As previously mentioned, that this year, in TAVR field, definitely memorable year. It's the Partner 3 trial, Eberhard trial was presented last month's SEC meeting. So we prepared this case. We're going to share our TAVR practice with the expert in the world. And I'm going to introduce our team. I'm D.W. Park from Asan Medical Center. And the first assistant, he is my friend, and he's James Flaherty from Northwestern. He's one of the top 10 centers in the United States. And my fellow is Dr. Go, and the assistant is Kang. Okay, we're going to start the case presentation.
Okay,
Dr.
sure.
Go, can you explain the patient?
Okay, sure. This case is an 87 years old female who is admitted to our service DOE, and she had a medical history of hypertension. Her echocardiogram is showing the very severe degenerative AS with LV normal function. And also she got the coronary artery disease, and we treated the coronary artery disease 1 month ago. And next. She got the hypertension, and the SDS score is 9.6%. And next. echocardiography shows a preserved ejection fraction with peak velocity 6.2 and mid pressure gradient also elevated up to the 92. And next. And this is the annulus measurement, and annular short and long diameter is 19.4 and 24.7. Annulus area is 365, and the perimeter is 69.1. And next. This is the sinus of Valsalva and the SC junction. The most important value in this slide is ratio relative to the annulus, and the sinus, the ratio between the sinus and the annulus ratio is 1.71 and 1.32 in SG junction. This is relatively smaller compared to our mean value. And next. The ratio between the LVOT and the annulus is also a little bit smaller than the mean value, 0.87. And next. The problem is, in this case, is total amount of calcification. The total amount is 504. Our mean value is 355. So this patient has a relatively severe calcification. And next. This is the longitudinal analysis of the calcification. Calcification is not extended to the LVOT. The calcification is located focally but significantly at the leaflet. And next. Coronary height is more than 10, is high enough. And next. Today we have chosen the Sapien 3 and the size 23 we have chosen. Usually our target oversizing is 10 to 15%. So 23 means 11% is totally within the range of our target. And
okay, the Professor Kim, can you explain the pre-TAVR echocardiographic finding?
Good morning, everyone. This is Dae-Hee from Asan Medical Center. Can you see the echo image right here? This is a transthoracic echo image, parasternal song axis view. Every function looks good. You can see severely stenotic aortic valve right here. In magnified view, the mild AR was noted during diastole. In short axis view, typical tricuspid morphology is severely stenotic aortic valve. In this is apical four-chamber view. Every function looks good. No regional or emotional valve right here. In CW tracing, the peak aortic valve velocity was 5.7 meters per second.
Okay, this patient is a very tight AS patient, and the contrast to previous case, this case is SA score is a 9.6, high risk patient. So, and the different style of the patient. So, usually our center, nowadays annual number of TAVR, we are doing the 200, more than 200 case, more than 90% of case we do just MAC and the monitored anesthetic care, and just some difficult case we do general anesthetic care. So, and any question or comment from moderator or panel?
You know, she's a high-risk patient, at least by STS score, but she doesn't have many high-risk features, other than the fact that she's 87. She's got a little hypertension, and she's got coronary disease, which is now treated. She's got normal LV function. And the anatomy looks very reasonable, pretty heavily calcified. You might consider, I mean, some people would predilate. On the echo, definitely. I didn't see it clearly, but I thought she had a focally thickened basal septum with what looked like a contact lesion. So sometimes you have to be a little bit tricky, because as you inflate and you deliver and expand the device, sometimes that can pivot you towards the aorta. So I would just be aware of that at least. And it's a little horizontal aorta, which again, you have to be very aware of.
Yeah, definitely.
Yeah, I think it's a very important point. There is a septal bulge, and the risk of proximal embolization is high if you do a quick inflation, like we have seen in the previous case. So very slow inflation is highly recommended.
Don't do a quick inflation. Definitely. We're going to show some different style.
And the other point is that
it's a very good point.
We predilate in very few cases, but in this case, I think predilatation is not a good way to do it, because if you do not predilate, the risk of embolization will be lower because when you start to inflate, the valve will be catched by the calcification, and then it will not move, even if you have a problem of pacemaker.
We would definitely pre-dilate this with a 20 balloon. At least that would be our style. I think there are a lot of ways to do it, but I think for all the reasons that Dae-Hee said, and a very slow inflation is very important here.
Okay, in this patient, is the SS score is calculated higher. The age is 87, and there is a coronary artery disease. What is the main component of the high risk of? What is the other? The only risk factor is age and coronary artery disease.
And advanced age and female is a big factor to the high score in this case.
So Marty, given some of those factors that you mentioned, do you think this is a case, if you had a fully repositionable and recapturable valve, that would be a specific advantage that might lean you towards one valve versus another?
I don't know. It's a good question. I mean, the only fully repositionable, recapturable is the Lotus, which isn't available in Korea. It just became available in the U.S. So they could use a core valve here. And I think there'd be nothing wrong. It's a little bit more difficult than a horizontal aorta to use a core valve.
Right.
But I think, I mean, they should get a very good result with the SAPIEN 3 if they just are aware of some of these minor anatomic features that we've been discussing.
Yeah, I agree. This is not an extreme case where that would be, I think, such a major advantage, but it is going to be an option now, at least in the United States, for us to think about.
Yeah, I think we wouldn't choose a core valve for this case mostly because of revascularized coronary disease, and we prefer to have the best access to the coronaries in patients who, you know, we might need to come back and repeat.
It's a very, very important point. I mean, that's going to be one of the biggest issues in low-risk patients, younger patients. It's not as easy to engage the coronary ostia through the frame of a core valve. And in this case, if they do it correctly, well, I shouldn't say correctly, but optimally, I think that they'd be able to access the coronaries above the SAPIEN 3 frame.
Right. So I think, so Marty, you think that the orientation of TAVR devices is the next frontier in TAVR evolution?
You know, it's funny. It was low on my priority list 5 years ago. Now it's very high on my priority list. What Vinny's talking about is to have commissural alignment with the native leaflets, which makes access to the coronaries much easier. And right now, we really don't have that with the current devices that are approved. There are some things we're working on to try to make that better, but that's going to be an issue in the future.
So, and this root angio shows we can see some slight Reinhardt, and then we usually the wire passage, we employ AL1 and next one. We used AL1 and the not easy to fast, and we changed the AL2. This is soft wire, and the soft wire easily pass that region. And then we put the AL2, and then we're going to change the safari wire. Looking at the anatomic picture of this patient, is a 500 calcium volume. In the previous years, we do routine dilation, pre-dilations. Nowadays, we have some change of our strategies. Sometimes some severe calcification, SAPIEN valve, pass is not easy. So people 400 calcium volume, we don't do pre-dilation. Above 400 calcium volume, we do pre-dilation. Usually 2 sides down pre-dilation. So, and I put the Safari 2 wire. This is a 2 sides down. It's the 18 GMAT balloon. Okay. Okay. Are you ready? Yep. Okay. Patient on. Okay. Inflate. Okay. Deflate. Okay. Patient off. Okay, got it.
This was slow.
What is the annular angle for the deployment? It looks like a little bit the horizontal.
자, 보면서 같이 빼세요. 자, 1, 2,
I mean, the key is, have the wire so that it is a horizontalish aorta already. So when the valve comes down, it's going to hug that corner. So
okay, got it.
To be able to pull it. Otherwise, they'll have
and
time
then the
passing
3.
through, but it should be okay.
I think that's another advantage of SAPIEN Ultra, that it has got that beautiful distal flex, which we have seen. You can, in these calcified valves, you can lift it up in the center.
Yeah, right.
Yeah, I think if you can orient it, if you can deploy from a central orifice position, it's always an advantage.
Okay, this is a SAPIEN 3. And 23, we are targeting usually 10% or up to 15% of sizing. Okay, push on, push on, push on, push on. 자, AP 맞추고.
네, 맞추고
자,
있습니다.
push on. Okay, got it. 자, AP로 맞추고. Okay.
I mean, you're seeing that routine TAVR probably takes less time than routine PCI right now. The average time of a procedure in Partner 3 in the TAVR arm was 58 minutes.
Yeah, means I think with this minimalistic approach, things have become so streamlined now.
Okay.
And I think with even better results that you don't need TE now. Sizing is very well done on CT.
Okay.
That's good.
Will anybody use any stiffer wire in case of very horizontal aorta and calcified valve? Like theory, would you, because you don't BAV,
Yes. Okay.
in these cases, would you still use Safari or you would use something else?
No, I
Okay.
use a
자, 그
conventional wire,
라인 맞춰놓고.
extra stiff wire.
자, 이게 같은 뷰죠? Okay, got it.
I like very much to shape the wire
Okay, got it.
according to the size of the left ventricle.
Okay.
Of course, you can use a small Safari or medium Safari, but
Okay,
I think
great.
it's less costly and it's as
Okay,
good
great.
as a
rock.
Safari wire.
Okay, wonderful. Okay, so Reinhardt is make some, horizon, the parallel plane is sometimes difficult. Okay, test.
Test here.
Okay, slightly more.
Picture.
So you see the top of the frame.
Okay,
Whoops,
slide.
it dropped a bit, so we're going to have to reposition it.
Okay, got it.
Yeah.
Okay, test.
Test.
Too low.
Okay,
Yeah, it's going to be too low.
Okay, got
That's
it.
better.
Yep.
Okay, test.
Test here.
Okay, I think the
You like
position
that,
is
guys?
good.
Panel, you like that?
Okay, usually we check the proto.
She's tolerating it just fine.
Okay. 자, 끝에 요거 안 들어간다.
You need wire?
해주세요. Okay, I need wire. 자, pressure is okay.
We just go slowly with the inflation.
Yeah, definitely some different style. Okay, got it. 자,
예, 되겠습니다.
잠깐만. Okay, 에어 빼고.
Right. If you go slow.
예, 됐어요? Okay, 됐어요? Okay, test.
Test.
Your pig is very high.
Okay, I
You
think
like it?
this is location is good. Anytime I can stop it. Are
Slightly
you
low,
ready?
you think?
Okay.
It's slightly low at present.
Okay,
low.
pacing on.
NGO.
Contrast. Okay, inflate. 쭉 inflate. More faster. Inflate.
No.
Okay. 1, 2, 3, 4, 5. Deflate. Okay, pacing off.
So the view wasn't perfectly coplanar and probably was positioned a little bit deeper in the ventricle than we would normally.
Yeah.
But
Okay.
I think you'll have a good result.
Okay, I'm gonna check the. 요뺑당기지 말고.
네.
오케이, 자 줌하고.
Good.
오케이, 자 줌.
좀 똑같은.
자, 오케이, and you ready?
Yep.
풀샷.
풀샷.
오케이. Can you check it?
Put it
Echo.
on lead.
튜브 좀 올려주시겠어요?
튜브 조금 올려주세요. There is looks like some the PVL. There is some effect of the wire, and we're gonna check it the echocardiography.
Because you have a lot of experience of the TAVR using the SAPIEN 3.
Yes.
As we know, the SAPIEN valve system had manipulate the angle of the caster. So when you advance the SAPIEN 3 from the descending to the ascending aortic arch and ascending aorta, there is some patient with a very severe calcification in the aortic arch. Therefore, we have to confirm the course of the caster delivery. Do not damage it to the ascending aorta. So
definitely.
Actually, this is the educational session. So you have to show it that the safely advance the sapien 3 valve through the aortic arch.
어때요? 잠깐만요. 네. Okay, Professor Kim, can you comment the immediate echo finding?
Wait a minute. This is the parasternal long axis view. There is no twice parabolic the ivory junction and short axis view.
조금만 큰 소리로.
In short axis view, almost no leak here, but I'll check the apical chamber view. Wait a minute.
Please continue comment.
I think the main reason that people consider post-dilating, of course, is to reduce paravalvular regurgitation.
Yes.
But I will say with an intraannular device, you always have to be mindful about what the gradient is going to be.
조금만 이쪽으로 쌤 안쪽으로
So we also
다리가
don't like
걸렸어요.
to leave the lab with a mean gradient of greater than
들어갈 수가
10
없는
by echo.
요거를 쌤 안쪽으로.
So we would at this point exchange the wire for a catheter so we could assess the hemodynamics and get rid of the wire pinning open the leaflets.
Okay, got it.
Yeah, I agree, David. I think that's something that a lot of people would do.
It doesn't.
You can pull it back to the softer part of the wire, and it tends not to pin the leaflets.
어떠세요?
But with the pre-shaped wires like this, many times you lose wire position when you try to do that.
Yeah, I think it's, it's no, you just put a pigtail in and let it sit and float, and it'll.
Almost now.
Okay, what about the echo finding? Is there no PVR?
Yeah, it's just with the horizontal aorta, you're going to be more likely to pin that.
Hopefully, we have a lot of time to discuss. Actually, 2 procedures was completed successfully within a very fast time.
What is the interaction between that septal bulge to the distal part of the valve? Is there any interaction there?
Twice parabolic.
Twice. Okay.
I mean, looking at the long axis view on the echo, it looked like it was well positioned.
Okay. Put the wire more.
It actually was just right on the verge of where that basal septal bulge was. So I think it's okay.
1 to 3, 1 to 3, 1 to 3, 1 to 3. Okay, we're gonna measure the hemodynamics using the pigtail. We're going to show the AR index.
There is some question. In what situation would you predilate the aortic stenosis? The question is what is the indication for the predilation for TAVI?
Yeah,
so usually
if you suspect coronary obstruction, that's a very good indication. If you choose the right size balloon, you can make sure that you're not going to obstruct coronaries. And then if you do, then you have to protect them somehow. The second thing is not in native valve, but if it's a horizontal aorta, stenotic bioprosthetic valve, this is something if we predilate with a very small balloon because it facilitates crossing. And that's one indication where we sometimes use Lundequist wire as well.
We're going to exchange.
I think other than these 2, I don't know. There's
what
any
about
other indication.
bicuspid?
I think predilation is needed.
Yeah, I think whenever there's really heavy calcification where you don't think the frame is going to get complete expansion, I think that it's not unreasonable.
Especially when you have a bicuspid valve.
Okay.
Then
제로잉하고 다 보여주고 있어?
around 10% of cases, no more.
And I would argue that for some of the self-expanding devices that don't have as much frame rigidity with expansion, and the ones that I would mention would be Symetis, even Centera. You routinely predilate those, and with larger balloons.
So we're going to
maybe Vinny and Marty. So in terms of coronary obstruction, right? So the core valve, you can see where the highest point is because there's a C on the taps. Would it be helpful for the balloon expandable to also have some marker where one of that left right coronary?
We usually the both side.
Chemistry, because then you can see really how it is aligned.
This is a femoral.
Not quite sure change anything you do, but
the short answer is yes, and we've actually been asking about this for a while. It's a great thought.
So we have a project running in Columbia at present.
So and can you see the hemodynamics?
Yeah.
Yes, perfect.
Yeah, said, you know, some
Excellent.
air index more than 3.0 is that there is no pressure gradient, is excellent. And, you know, we're going to check the final angle and remove
the diastolic pressure is 60, so
yeah, definitely.
I don't think there's going to be much AR.
EDP is 10.
Okay.
It does show you that you really can pin leaflets so you can get a skewed representation when you just do an aortogram after the procedure if the wire is still in.
자, 센터에 놓고.
So Mario, on a low risk trial, the average stay is also still 3 nights, 3 days.
I'm sorry?
That, you know, the low risk trial, they stay in the hospital still 3 days on average, right?
풀샷.
The low risk trial.
Excellent. Yes. Area view.
Yeah,
okay,
very
sorry.
nice. So the median length of stay was 3 days, yes, mean and median. Although it's really not what we do in clinical practice anymore. Our median length of stay is 2 days.
Wonderful. Previous one?
Between 1 and 2 days.
Yeah. So, and this is our final, the aortogram is, there is no AR, just trivial AR, and
very nice.
There is the position is good, and you know, so influation time is different, previous one. I think even though this is a patient is very old, 87 years old patient, the result is good. I'm gonna very happy shows our routine type of performance in Asan Medical Center. It's a very honor to share the knowledge with my friend James Flaherty.
Excellent job. And then one of the issue is this patient was underwent the PCI procedure 1 month ago. There is some discussion about that. Is the simultaneous fixing stage?
Definitely,
So what is the opinion of that?
Yeah, there is the nice question. You know, this is depending on the coronary anatomy complex. The simple region, we do usually the same stage PCI and TAVR procedure, but this patient is severe calcification requiring complex long region implantation and the right and the left, and at that patient, we're going to do stage the first PCI and then the TAVR procedure. And depending on the coronary anatomy, we decide to same side or stage PCI.
And when you do PCI in these patients, do you do BAV as well at the same time, just to make the patient more stable during PCI?
Yes, you know, during the PCI, patient was stable. At the time, we didn't do the BAV. Sometimes, you know, I'm concerned about at the time of the BAV, some patient experience very acute AR at the time. So we have no choice. We put the TAVR valve implantation. So that is our, you know, strategy. Okay, any comment from James?
So the EKG has remained normal. Does this patient go home tomorrow?
It's, you know, so we usually take care in the coronary care unit 1 day. The patient ECG was normal. Our data is 650 case after SAPIEN 3 implantation. Pacemaker rate just 2%. Absolutely very nice. Every load is some different. Yeah, so it's I think pacemaker implantation rate with the SAPIEN 3 it doesn't matter.
Okay, excellent job. We have another cases.
Okay,
we will move the third cases.
Thank you.
Thank you. Dr. Han, Dr. Grube.
Yes, sir. Good morning, audience. Good morning, Dr. Hong. Good morning, Dr. Martin Leon. This is the third live demonstration case of TAVR. I'd like to introduce, I'm Jung-Min from Asan Medical Center. Beside me, very famous Dr. Eberhard Grube and Cheol Lee will help us today's live demonstration. So I'd like to briefly introduce our case. This patient is a 71-year-old female admitted for the approach chest pain. And
please show us this slide.
Could you show us the slide? Okay. This is a 71-year-old female, the approach chest pain and abnormal echo findings. She had a medical history of hypertension, diabetes, and PCI 6 years ago at RCA, and left carotid stenting a month ago. Echo showed a severe degenerative AS with a normal elbow ejection fraction. Risk factors are hypertension, diabetes, had a history of PCI at 6 years ago at RCA. Next, please. So the STS score is 3.8, so definition-wise low risk patient. Next. So echo showed the ejection fraction is 78%. Ejection fraction, L12 area is 0.53. Pressure gradient is 127 and 79.
Wow.
Next, please. This is the CT findings. Annulus short diameter is 17, long diameter 23. Annulus perimeter is 63. Next, please. The sinus valsalva is relatively small, and sinus tubular junction is relatively small. Next, please. LVOT is small. Next, please. The calcium is not so big. Our center is already we quantified the calcification, each leaflet. So total calcification volume is 143. Our center's mean amount of total calcium is 350. So 143 calcium volume is a relatively low calcium volume. Next, please. Next. The chlorine height, left is 11, right is 15. Next, please. Prepara is 5.3, right side. Next, please. This, we will do the self-expandable device with Dr. Grube. So we selected, we tried to select the 26 Evolute Pro. Do you have any comments or a question?
Maybe we have a lot of comment about it. Is there any comment or question about this case?
Maybe I can comment about this. I think the Evolute Pro in this case is a very good choice because the mean diameter is 20.2, so it's too large for a 20 S3. It's too small for a 23. So Evolute Pro in this case will be a perfect fitting with the annulus anatomy.
Yeah, I would agree. It's, I mean, the one valve of the S3s that we don't like to use very much is the 20. The gradients are, somewhat higher with that, and we've had early failures, and so we really try to stay away from the 20 millimeter S3 and use a core valve with, take advantage of the supraannular location, get a little bit larger annulus.
Yeah, I think also the sinuses are just a little bit effaced. I agree. We do not like to use the 20 Sapien 3 unless we absolutely have to. Maybe a little bit different with the Ultra, but we'll get more experience and we'll see. So I think this is a good case. I'm impressed with the severity of the AS. I mean, she's got a peak systolic gradient of 126 and a diastolic and a mean gradient of 79. So this is
real deal.
Real, severe AS. So I would. And she's got an EF of 78%, so she's generating LV pressures that are, in the mid-200s. So it's, it's very impressive, the severity of her AS.
The main difference of the partner 3 from the partner 1 or 2 is the patient age is quite lower, middle 70. So before the partner 3, we have some discussion with the heart team. Usually the surgeons may argue about the patient age. Yeah. So the middle 70 is still younger, still healthier, and they raise some question of the durability issue in a long-term follow-up. So anyhow, after the publication of the Sapien, the partner 3, the attitude of the surgeons might be more mild and mild for the type of procedure. When I look at this patient, the patient age is 71, right?
Yeah, right, 71.
71. What about the surgeon's opinion in the heart team of discussion?
In our center's heart team discussion, are you asking me?
Yeah. So I think.
Does the coronary disease affect your decisions? I mean, we're just noting that LAD is heavily calcified. This is not a good view, of course, to tell, but it looks like there may be a moderate or severe stenosis there. So it's not inconceivable that you would need to get an atherectomy burr through that at some point.
And also recognize that at 71, with this degree of coronary disease already, you're going to need access to those coronaries.
Absolutely.
So just be aware of that.
That LAD would concern me. Well, what does it look like now? She's had an angiogram. What's the LAD look like?
we already evaluated coronary angiogram for LAD. LAD looks fine.
Sure.
So the RCA already stented. RCA stent is patent, so we don't care. But yes, you are right. We have concern about the future access to the coronary intervention. This is your real concern.
So Dr. An and Eberhard, Evolut Pro versus Evolut R, why do you choose the Pro here?
Yeah, we've discussed that. First of all, before I get into this, I've been listening now for an hour about everything that you've said. And now I just want you to understand this is a core valve case. So I was thinking maybe we do a Centera now to be in line, but they don't have Centera yet. So, you know, I wanted to thank SJ and Jung-Min that they have me back here. It's always a privilege to be on stage with this young man who I believe is one of the best core valve operators that I've met. And by all means, I didn't want to miss this, so I took the last flight out. And the team here, as you all know, is very, very experienced. I didn't have much time, to be honest, to discuss the case, but I believe everything that you said before is very well taken. In some points, I do agree. In some points, I humbly disagree. But here, I think the challenge that we have is the peripheral axis is 5 millimeters. So the question then, even more important, comes up, you know, whether we should take the Pro or the R. You know, here we have calcifications. Obviously, SJ and the team here, they have their routine, and their routine is maybe a little bit different from others, but we have to accept those things. And personally, I think I would, here in this case, would not pre-dilate. I'm not so much concerned about the coronary axis. To be very honest, I went through the cases that have been described. To me, there's also a little bit of a, well, how can I say, a little bit of a saying that this is more difficult. I'm not saying that the coronary axis is of minor importance, just the opposite. Also, the difference between intra and supraannular have to be discussed, particularly in the younger patients. If we have two supraannular, valves in case the patient does have a valve and valve, all these things come into the game now that were not all that important before. And I think here we decided for the Pro calcifications. The axis will be challenging, I have to say, and we hope that we're going to get through simply because of the fact that the Pro has less PVL in this calcification situation. We'll see whether we can pass the 5 millimeter vessel. But the 5 millimeter situation in itself is speaking, in my view, for the core valve, because it does have one of the lowest delivery catheter, and we're planning to do the inline sheath. And we, at least unless he has changed his mind, we do not pre-dilate in this case. We'll see, whether we have to post-dilate depending on the situation. But having said that, it's great to see Dr. Hong on stage there as a chairman. Good morning, Dr. Hong, and then all these good friends in the panel. You're so smart all that I'm looking very much forward. You teach me how to do this right, apart from Jung-Min, who obviously has his head. He doesn't talk much, but he knows exactly what he's doing. So even I'm going to be quiet next to him. So remember, the axis will be a little bit challenging if we don't get through. The good thing is there's no circular calcification, so I'm quite optimistic. Then we would maybe do propofol in case it doesn't slip well, but we'll see how it comes along, and then we can discuss. If it doesn't come along, then all your comments are very well accepted.
And Alain already asked you that what is the difference between Evolut R and Evolut Pro?
Yeah.
What is the benefit of Evolut Pro?
Well, as you know, Alain, the benefit is obviously the rep addressing the PVL situation. Now you pay for it in terms of a little bit of a larger, 1 French more delivery catheter size, but here in this case, I believe that looking at the inline inline sheath situation, I think we can do it and take the advantage of addressing the PVL, particularly now in terms of excellent S3 results that we have seen before.
In the angiographic appearance, the stent in the right coronary artery was deployed in the proximal RCA. Did you confirm that the proximal margin of the stent was beyond the arcing of the right coronary artery or not?
Yes, the OC is not covered, so it doesn't matter.
Okay, shall we go?
Yes. I think
I know
just a comment
could you show us?
related to the earlier question about the heart team discussion. And this is, I think we can definitely implant TAVR, but the key thing here is that the anatomy is favorable in getting good result. This is the discussion we always have now in Colombia, is we have graduated from can we do TAVR to can we get the best result. And if there is any doubt about it, say calcification pattern, risk, anything, then this patient then would go for surgery. But otherwise, we're quite comfortable in doing a TAVR in such patients.
Also, Vinny, I think this is a very important point. Let us not forget, as important the low-risk trial was, we also have to pay a little bit attention to the patient selection in these two trials.
Next.
The real issues with TAVR, these patients have been taken out. No bleeding risk, no bifurcation, outflow tract calcifications, all of these things that make life a little bit harder for TAVR have been taken out. And so, you know, I think so many times and so many years, cardiovascular surgery has been pronounced dead. And we just have to weigh it very carefully, as you said, with a heart team decision to make the best choice for an individual patient, even in today's world. I don't think anybody would doubt that TAVR is going to be the future, but I think there are very, very many patients left where surgery is just simply a better and safer choice.
Yeah, we should.
Yeah, I think, of course, that's true. I would say in a case like this, we probably would have enrolled the patient in Partner 3. I mean, there's coronary disease, but that is allowed as long as it can be managed with angioplasty, either during or before. It's not a bicuspid valve. There's no calcium in the outflow tract, but there's a fair amount of calcium. But so I think this would have been a case for both the Evolute low risk and the NP3.
Yeah.
So Marty,
Yes,
if you use the Sapien 3, will you use a 20 plus something or 23 less something?
Yeah, I would prefer to use a 23 less something rather than a 20 plus something. Yes.
It's Dr. Martin Leon. So after the successful partner trial and ever low risk trial, my understanding is the discussion about the clinical risk profile is it doesn't matter anymore. So the important thing in the future is that who need surgery, who need TAVR in the low risk patient. So do you have any idea who definitely need the surgery nowadays, or yes, personally I think almost all cases we can do the TAVR, but is there any specific
well, of course, I think that there are extremes of coronary disease, there's bicuspid disease, there are extremes of calcification, there are other anatomic features. Remember, Partner 3 was in only patients that had transfemoral access. And even though Evolute low risk allowed a transfemoral, 99% of the patients had transfemoral access. When you add all of these things up, there may be as many as 20% of the low-risk patients that would do better with surgery. At least that's what we think.
Yeah.
And we need more data in some of these other subgroups.
And I think in younger patients like this one, for example, we have to think of second intervention.
Yeah.
I think that's going to pan out with time, that if we need a second intervention, there's not much surgical experience or TAVR in TAVR experience today to confidently say that one will work better or surgery will be more difficult. So I think we just have to wait it out and then see where the evidence takes us.
Denny, does the second procedure bother you, or is it the third? Because to me, it's not the second, it's the third one that starts to get me.
I think, right, David, if you're starting to talk about 65 years old, then you talk about three valves potentially, right? So that will become a little.
I think that starts to get prohibitive.
What comes second, and
yeah. I mean, I'd like to be able to get patients through life with 2 TAVR valves.
Yeah, and I must say, no one talks about it, but but I don't know what the longevity is of a valve-in-valve.
TAVR, yeah.
I mean, we only have 3-year experience right now in terms of duration of follow-up in valve-in-valve for surgical bioprosthetic valves. We don't have essentially any data with a TAV and TAV. So the assumption that, well, you can get 10 years in one and then 10 years in the other is really well beyond what we know for a fact.
But Marty, one of the good trends which we saw in partner 3 was at least the surgeons are implanting bigger valves. For some reason, that was a very obvious thing.
Yes, we browbeat the surgeons, and we were shocked at. It really was a big difference in prior trials, and I think it's a good thing.
Yep.
So you're watching a very experienced team.
That corner.
This is with the online sheath.
Yeah, that corner is a little tricky.
I mean, here and you see the calcification, how difficult that is.
Be careful.
On the bifurcation side,
Be careful.
Because at the axis side it was 5.2, and then at the bifurcation there was that was 5.0 with a little bit of with calcium.
Now
and you can see exactly where it is now.
The left looked a little bit bigger.
Yep.
Yeah. Here.
Yeah, it's just that you're being biased into the wall on the calcium. The lumen looks okay.
And the transition of the evolute is from that little head.
So another thing that a lot of people in the States are doing now in these borderline cases is they're using shockwave to pre-treat some of these lesions to see if you have a more compliant.
So some rotation would be.
I think that would be a nice option here.
You could put a wire next to it.
Or a balloon, all kinds of stuff.
Maybe you need to check it with the angiogram, and then use the
런더캐스트, please.
check it first, and
do you want to do the propofol?
Yeah.
dilate the peripheral vessel, or using the sheath.
We have sometimes
it's beautiful to see.
E-sheath or any other expandable sheath.
Yeah.
프로포폴 좀 주세요. 프로포폴 좀 주세요.
So one of the problems is that the aorta is very small, highly calcified. So you can leave the inline sheath where it was and then push the valve, leaving the sheath at this level. Or you can make some rotation, 15 degree, 20 degree, and in one way or the other, and you can solve the issue.
And also sometimes the delivery system is oversheathed or undersheathed. Make the gap.
Are you doing it? Are you doing it? Propofol? Okay.
So we see the contour of the aorta, which looks very, very small, less than 20 millimeter.
The valve size is small, and when we look at the distribution of the calcium in this patient, it looks like some small. So we have to be careful.
So Dr. Han, your plan is to use propofol to
sliding 런더캐스트. Yeah.
You have it?
Yes, I like to change the wire to the 런더캐스트.
You have it?
바른다고.
You don't have it?
Did you try to leave the inline sheath at where it was and then just push the valve?
So, could you give me the 런더캐스트 wire?
Yeah. I'm ready.
네.
So your
Well,
plan,
when I have a situation like that, what I usually do is approach that bifurcation with calcification in a rotational fashion, not let it go until it stalls, and then kind of push. I would try to transition into a rotation and then have it slide up.
can also think about putting the Lundquist in the pigtail from the left to hold the other side so that it doesn't bend.
The other side open, yeah.
Yeah, so that might be also to counterforce your gentle pushing.
Just an ample, you just have to cover it there. Yeah.
This is Lundquist wire.
So this is a Lundquist wire
Yes,
that was
right.
put through that pigtail. So it's always a good idea to use a stiffer wire in a situation like this. But there are so many different tricks that people use. I'm confident that they'll solve this problem. But
Probably. How many experience of the Lundquist, particularly in the cannulation in the left ventricle? You know, Lundquist is a very stiff, so we have to
Ready?
So usually, most of the patient ones are just the Sapari and the other.
Just give me the stuff.
when there's a fair experience, actually some centers prefer to use the Lundquist. But it's a very stiff wire. It's going to drive you to the outer curve of the aorta. It's going to bury deep in the commissure, and it's got a higher risk of LV perforation. So you've just got to be aware of all those things.
So the Alain,
actually, this is totally the unexpected finding in this procedure usually. So, real life cases.
Yes, yeah. I changed
Please
the wire
show
to
us
the
very strong impact of the type of procedure.
So I changed the wire to the stronger Lundquist wire, and Dr. Grube prepared the propofol.
Yeah.
Please remove the wire. Be careful the wire. Okay. Please.
Put the energy.
When you push the Evolute Pro in the bifurcation region, not simple push, it's a rotate and slowly advance it.
But my feeling is the wire is too weak, so to push a lot, make some. Yeah. Okay.
Please show us the lower part, fluoroscopic
So always
imaging.
make sure that the wire in the ventricle
Lower part.
is going to be there.
Slowly.
Straight to wire, please. Be careful the wire.
Yeah.
Keep the wire.
I'm keep the wire.
Zoom out in the whole thing.
Yes, I zoomed out.
Okay. More rotate.
Wire.
Yes. Please keep the wire. More. Okay. Okay.
They're being very careful not to lose the ventricular position of that wire.
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 Straight. No. Straight, please.
Okay.
I think it's the sheath edge is hitting that chunk of calcium.
Yeah, exactly. That's a little bit of a. There's a little bit of a. That's why.
Can you bring
shockwave is this the Evolute Pro or Evolutar?
That's
the Pro. Evolute Pro.
The another option is to change the Evolutar simple.
Okay.
When you get shockwave, this will be a great application for it. It really fractures the calcium. It makes these deep rents in the calcium, and it really improves the compliance of the vessel. It's being fairly widely used for peripheral access now for TAVR.
Is it coming?
Yeah.
See that?
Wire.
Keep the wire in.
Keep the wire in.
And use the advantage now.
There you go. All right.
Excellent.
Excellent.
Bravissimo.
More exciting than the previous two cases.
Means the other choice would have been to puncture the left side and take that curvature out. Would you do that?
So
No, the left side looks worse, Vinny. On the calcium.
You know, Eberhard, surgery is always an option.
I know. Thanks for telling me that now. But I know you're a friend. I told you, now we have all good opinions.
please change to the implant to Zoom, please.
Okay.
Test, please.
So as you noted, there was no predilatation, and the valve went across. Pretty good.
Yeah.
No, you do.
Test.
And we have tried to aim, around 3 to 4 without...
Test, please.
Okay. Start it.
Yeah, you can start always a little bit lower and then pull it up.
Yeah.
So no worries about it. Can I start?
Yeah, start.
So as you know, we do this a little slower in the beginning. We don't want to have another pop out here.
Test, please. Okay, good.
That part I like to do slow. I can hear you smile, you guys.
Test, please.
No, it's looking good.
It's a very sensitive
Okay.
microphone. So be careful.
Just for a while, slow. Okay.
So I'm getting even slower now. The pressure's good.
Yeah.
So are you pulling back at all? Or are you...
Test, please. Yeah. No, not deep.
It's pretty good. Pretty good. It may have gone
I
in
think
a
it's good.
millimeter, but
Yeah,
It's a bit lower than probably.
Yeah,
Yeah.
it's a little
Going
bit
down.
lower than you might have wanted.
Can you go?
Yeah.
but it's not going to pop out.
No.
Okay.
So when it flowers and contacts the other wall, it's a little bit more difficult.
Right.
The hemodynamics is very nice. Test, please. A little bit deep.
Yeah, that's
Well,
what
at least there's no
everybody's
weight.
saying. It's not going to be a pop out for sure.
I think you have to recapture. Does the type of wire make a difference as well in ability to manipulate?
Yeah, I think.
It's hard
What do you want to do?
Stiff wire, yeah. It's stiff.
So I think it is good, but try 2 or more. Yes, let's do try 2 or more. We have time.
To do what? Resheath?
Resheath.
Yeah, I would resheath and go higher, to be honest.
Yep.
Everybody agreeing?
We love that
Yes.
decision.
Yep.
Yes.
Yes.
It's nice to have one deployment to stretch out your valve a bit sometimes with these tight,
Thanks.
it actually helps to get it sort
I
of
think you have a
centered.
very nice
And
position
then do a
now,
second
so you
deployment.
can
Now, many
restart.
times when you resheath, of course, you don't have to fully resheath. So,
Right,
and the way
it's already
Eberhard did it
come
is
back.
really perfect.
Keep it there, that's good.
Yeah.
Good.
So now he's restored the mobility of the device. It's not completely flower to the...
No,
Lay
I just,
with- it's much,
as
much
soon
higher.
as soon as there's contact, I go faster.
And we can lay it on the other side as well.
This looks a lot better, Eberhard.
Yeah.
Looks perfect. 3 or 4
This is
depth there.
very nice actually position.
Yeah, that's several millimeters back.
Test, please.
That's nice. That's actually really great.
That's good.
Okay.
Yep.
But I push a little bit.
It will lay over a little bit, so the left side will be a
Okay.
little higher when you final
Yeah.
position. So
Can I do
Yeah, that'll hopefully self-start.
Okay.
yeah.
Just for a while. I like to stay more time until the full expansion of the device, and then deploy.
Okay.
Good.
I do what the boss says.
Test, please.
You know,
Are you all
these
satisfied with?
these injections are not for PVL, as you all know. This is not PVL assessment. This is depth assessment.
Yeah.
Because you're injecting outside the valve. So
We're very happy.
I think the
this
depth
is a really nice depth.
I think the
it looks
depth
good.
is good.
So or you are satisfied with this depth?
Yes.
Yeah, yes. Waiting for a while and try to slowly deployment. And just a moment.
So here-
to release the tension.
Here I would not
push a
release
little
too
bit.
much. Yeah, push. Here, this is the situation where I would push a little bit.
Yeah.
Will you remove the pigtail before?
No. Don't even talk about it, please.
No, pigtail's fine.
Okay.
Okay. Good. Very nice.
Okay.
Leave everything. I like to leave.
Make sure that you don't
center the wire.
pull the valve up.
Yeah.
Moved. It moved.
Now you got a 0 depth.
It moved.
Let's see.
It's
Can we pull
half in,
the
half out now.
pigtail now?
Yeah.
Yeah, it's always good to get the nose cone up,
Wire 주세요.
Maybe we can.
Yeah, if there's any issue, it's always good to wire the pigtail before you pull it back.
Yeah.
Yeah.
Now, can I?
에코 좀 봐주시겠습니까, 선생님?
Is that pigtail mobile?
Yeah. The pigtail.
스티브 와이어 주세요.
그냥 저기 테프론 주세요. 테프론.
Very nice.
오케이.
I think we need one more valve.
Yeah, I guess so.
Yep.
Let's see.
I think the problem was probably the Lunderquist not allowing you to lift the nose cone in the middle.
Yeah, I think
you're right. The stiffness of the Lunderquist
tracks outside that forces you to scrape the valve.
Created too much interaction between the nose cone and the tip of the
pressure is lower. So could you prepare the one more
This is just a
device?
thought. Has anybody, when the nose cone is still in the ventricle, take the Lunderquist out and then put a softer wire? Is that too daring?
Yeah, let's just wait and assess the situation a little bit.
Yeah.
The echo is looking.
When you central AR.
Central AR.
From the wire.
Eberhard, have you ever accessed coronaries through two valves?
Yeah.
And is it easy?
Well, in my case, I was able to do it. But that's why I said the supraannular plus supraannular makes it maybe a little bit harder in the future. And that's something that we have to keep in mind. Can we do an echo? Can we do an angio?
Yes, angio, please.
So
remember when you ready?
Despite the wire, despite the wire, let's do an angiogram also.
Ready?
Yeah. So we need the second wire. So it's slipped up.
Yeah. So, please.
Now, are you thinking of an R?
Eberhard R26. Eberhard R26, please.
So now, guys, we're using the R, so we don't have to go through the bifurcation thing again.
R, Eberhard R.
It's going to be a valve and valve, so
26.
It's going to be okay.
R 프로파일 작습니다.
네, 주세요.
Low profile.
I agree with the Eberhard R rather than the Eberhard situation. And another, we have to concern about the possibility of the coronary obstruction of the two-layered portion of the valve.
Well, Eberhard.
Yes.
Now that the coronary is probably at the level of the fabric or the skirt, would you consider to pull this valve just a bit higher so that in the future you can still access?
I think it's a very good question. You could go either a little bit higher or deeper. Most likely, Paul, when we go in with the second valve, then you push the valve a little bit further down. So I would rather leave that there instead of pulling it up. And then with putting it up, you have to snare it and stuff like that. So I would probably go with the second valve, go in and do it. As you know, the valve and valve here is with the second core valve. You have to be very sure that the two meshes don't confuse you, because the depth here is obviously, and by own experience, you always know that you don't want to have a second pop out, so you normally implant a little deeper. That's a natural reflex. I hope that my friend on the left side here can resist that reflex and doesn't put it in.
So at this point, Eberhard, would you use an Evolute R? Do you need a Pro for the second one?
No. That's what I said. I think here we need the regular evolute. Number one, you don't want to have the same struggle at the bifurcation, knowing what we saw now. So we want to go up and take advantage of the low French size. And I don't think you need the ceiling at this point. So that's why I think here the R is a good option.
Fortunately, patient vital sign is stable, so we have time to prepare the next device.
Would you consider switching wires or still work over the Lunderquist?
I will keep the Lunderquist.
Yeah, the Lunderquist has an advantage, as Vinny said, has an advantage and a little bit of a disadvantage, because here you can see it very nicely, and it's not the first time that we see that. To lift the nose cone up is a little bit more difficult with the Lunderquist because he engages in the outer curvature, and it's a little bit more difficult to lift the nose cone up.
In this patient, the aortic valve area is the 0.5. If we dilate the aortic valve before the Evolute Pro, maybe the situation is similar or not?
No, I don't think it will make a difference, to be honest. I think what here was just obvious what happened. So you can always argue what could have been if it was different. So when we have a cup of coffee, he would probably say, well, why didn't you leave me at that depth? So now we have to deal with the pop-out.
Right.
So I'm prepared for that. That's very natural. But I still think it was a little bit too deep before, and I think it was a good choice to reposition it. The position was good. It just happened the way it did. And now we are hoping that the team here in the back can load the valve fairly quickly and to show you, not planned, a valve and valve.
Eberhard, a question about the Evolute Pro. I have the feeling that it's a little bit more slippery than the Evolute R.
Yeah.
And adding propofol to that maybe increase the risk of moving the valve when you have some conflict with the nose cone. So what do you think?
Yeah, I agree with you, Cherry. I totally agree with you. But it's,
Dr. Han, you have 4 minutes left.
Thanks. Oh, Dr. Hong, you're so nice to us.
And then the next session, we have the ceremony of the Master of the Masters. So
you have to rush.
End of the successful result will be show us later.
Always good.
Okay.
Yeah, which is
This
always...
is a very important case, so if there's a chance for us to be able to see this, I think it would be very good for the audience. It's very educational.
Which again tells us, we had talked too much beforehand instead of moving. But it's always...
No, you're fine. I just think working through these problems are very, very educational for everybody.
Yeah.
Dr. Han, can you show the root shot you just took before the last picture that
next previous one?
Oh yeah, it slipped quite a bit up.
Yeah.
So the left coronary now are they all covered by the cuff?
Yeah.
Mm-hmm.
So you won't be able to get access to it in the future.
Well, we'll see, Alan. We'll see when we move the valve, the second valve. We'll see whether we're able to push the valve down. And I don't know whether you can, we will be able to show this online. But what I would like to do, I don't know whether he agrees. I would like to access the coronary with the Judkins, and in case we are not live, we can show you, because I think it's an important lesson here.
Are you worried at all about the size of this valve? The valve is almost occlusive at the level of the STJ.
That's correct.
And it could be a stovepipe where the coronaries are completely occluded after this. That's, I think, so maybe it should be pulled back. Maybe that would be better.
Yeah, that's what a lot of us are thinking, that maybe it should be pulled back.
Otherwise, don't do it.
It should be pulled back.
I think it's just safer, probably.
Yeah.
I agree.
Don't pull back. I think it's going to be okay.
What do you think, Eberhard?
No.
You don't think it's not important?
You think?
I know it is very important.
No, but it's not the right thing to do. Why not?
No, because I think we're going to be okay. We can push it a little bit further down.
You think it's just going to push down? Okay.
Yeah. And then it's going to be okay. What's that?
This is tricky.
No, it's not tricky.
Not to you, Eberhard.
Okay, Dr. Han, 1 minute left. So I wanted to close this session and
So,
show us the excellent
guys,
result of that later.
And we will tape everything. We will tape everything, and then we show you. Okay?
Okay. Frankly
Thank you.
speaking, I
All right,
enjoy
thanks.
it. It's really very interesting. Live cases.